Hi, everyone. I think it's promptly 12:30, so we are ready to start. Welcome, everyone. We're really excited about today's session. And I just want to welcome you all. Caroline, if you are able to advance the slides. So we wanted just to begin with acknowledging the land that we're on today, particularly the land that I am on and my organization, Public Health Ontario, is on. That this is the land of Toronto to Toronto, the traditional land of many Indigenous nations, including First Nations, Métis and Inuit people, but particularly that this is the land of the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Huron-Wendat. And with that recognition, it's important for us to take a minute to understand what does that mean? What does it mean to be on colonized land? How do we all benefit from this colonization, including where my house is right now, who had to be removed from this land to make way for this house that I'm in, and how I, as a second generation immigrant, continue to benefit from that legacy of colonization. Next slide. So we wanted to also let you know that there's none of the presenters today have any conflict of interest to declare. The one thing in terms of previous work around demographic data collection, my colleague Caroline Benete-Bayesh had previously worked at the Sinai Health Systems in her role as part of the implementation team for collecting that data through the Toronto Central and hospitals and community centers. Next. And this is just a disclaimer that you're able to use this information as long as it's not for non-commercial purposes, and to kindly not change any of the content without letting PHU know in advance of that request. This is a brief overview of today's agenda. We have a packed day. So we're going to start with a quick overview in terms of why are we here, what's the objective, what's the point, as well as followed up by a quick overall presentation from PHU, just highlighting high summary of some of the provincial level data in terms of quality of the data that we're seeing. And then we are really grateful to have the experiences, the expertise, the stories from three awesome public health units, Peterborough, the regional municipality of New York, and Toronto Public Health. Then we will follow with some key questions facilitated by my colleague, Caroline, and then open it up for both questions and discussions, and then kind of end our time together exploring some future training and education needs. With that, I just wanted to go through very quickly some house rules, or not really house rules, just just key information. So as you're all here, your mics have been muted. However, so we would like to continue having your mics muted. We encourage anyone who can to open their cameras. It just creates a sense of togetherness and seeing who we're talking to as opposed to the abyss. So grateful for my co-presenters doing that. But if any of the participants would like to show us who they are, we're more than happy to see them as well. Also, that there will be a chance to you have an option of either choosing to use the chat box throughout the presentation for any comments or questions that you might have, or alternatively during the question and answer / discussion period, there is an opportunity to raise your hand and unmute yourself if you would like to either make a comment, share your own experiences within your public health unit, or direct a question to any of our fabulous presenters. So just to understand who else is in the room, we wanted to start with a quick poll, just to understand where people are calling in from or joining us from. And you should be all able to see the poll. Also, numbers are coming in. Awesome. I'm going to give it one more, maybe 30 more seconds. Great. I don't know if people can see the results, but we have a really great representation from Toronto, Southwest, as well as Central East and Eastern Ontario. Great. Next slide. So today's presenters are myself, Samia Abdi. I'm a senior program specialist at Public Health Ontario. My colleague, Dr. Pam Lees. Caroline, can you go back one slide? Thank you. My colleague, Dr. Pam Lees, who is a public health physician, and my other colleague, Carolina Bennett Abayash, who is a knowledge exchange specialist. Also a wonderful, amazing, really loud shout out. And if people can use the emoji of clapping to our amazing experts and presenters of today, Dylan Milmer, an epidemiologist from Beta Pro Public Health, Dr. Fareen Karachiwala, Associate Medical Officer of Public Health, Community and Health Services. It's really a long title, Fareen. Representing the regional municipality of York, and this Carson, Supervisor at Epidemiology and Data Analytics Unit at Toronto Public Health. And I'm going to use this as well. Thank you all for joining us and sharing your expertise with us today. So why are we here today? We are hoping to share, as mentioned, a little bit of information in terms of a quick high-level summary of some of the data that we're seeing across the province. We would like our panelists to highlight some of their experiences, challenges, opportunities, solutions around the social demographic data collection. And finally, for all of us to have an opportunity to explore what are the needs of public health units and those who are doing the work on the ground in terms of future training and support from Public Health Ontario. Next. So I'm going to invite my colleague, Pam Lees, to share some information for the next few slides.
Thanks, Samia. So I'll just speak to two slides at a high level as a facilitator from our health equity group, but I really want to credit our colleagues in the epidemiology team for pulling this together and their collaboration with us. And Karen Johnson from the EPI team is available on the call for the discussion portion, as we're focusing mostly today on discussion. So just to show a high-level summary of the completion rates at the provincial level, we are looking at by week here, and the blue bars are for COVID cases by week, and the black line at the top is showing the percent of completion on any of the SES questions over time since the start of the data collection. So seeing that for completing one of the set, at least one of the set of the questions, there was around 80% at a lot of the time points, with a bit of a dip that I think will come up in that'll come up in our conversation later in September and October. So that's the overall by week pattern here. And then just the next slide, Caroline. So we just wanted to give a sense by question. As you know, there's the set of 5 questions that were introduced in late June. 2 of them here at the left-hand side on language. So for the official language that people are most comfortable in and the first language learned in childhood. The completion rates were just over 45%. For the income question, we had around 47%. And then with the household size and race or ethnicity, the completion overall for the questions at the time point of this analysis was over 65%. So that's just to give a high level summary at the provincial level, and more discussion we'll have along the way, and with support from Karen Johnson, and I see she said Vasuja is available from the team as well. So I'll pass it back to Samia.
Great, thank you, Pam. And again, so there will be an opportunity to go back, to come back if there are other questions or particular questions or comments around these data elements that have been shared. And thank you, Karen and Patricia, for being with us and all the amazing support that you've been doing for this work. So now, the most exciting part of this presentation, having our three colleagues and presenters share their stories and their experiences. So I would like to welcome Dylan Milmer as the first presenter. Oh, you're on mute, Dylan.
Hi, thank you for that very nice introduction. This is my first webinar, so be patient with me. I'm fairly new. I just got hired in October at Peterborough Public Health, and one of the first projects that I was tasked with was looking at the socio-demographic and socioeconomic analysis for the local COVID-19 cases. Next slide, please. So the total population of Peterborough Public Health that we look after is roughly around 148,000 people, with our people who identify as a visible minority roughly making up only about 5% of that. So we don't have a very diverse population within the Peterborough area. We serve residents throughout Peterborough City and County, as well as Curve Lake and the Hiawatha First Nations peoples. Next slide, please. So the practical issue that I would like to speak to today is my original intention with this presentation was to touch on the fact of how missing data and how data collection leads to missing data and the methodologies that are inherent there and how you can get some bias. Because unfortunately with sensitive data collection like this, it is just naturally prone to bias and missing data due to various other reasons. So when I pulled this chart off of our local COVID tracker website, we had just over around 240 cases within Peterborough. So it's a very small case size relative to other health units. Next slide, please. But however, with regards to socio-demographic data, we had a lot of missing information. As we know, in July, local health units were enabled to collect socioeconomic and socio-demographic data. And actually, Peterborough wasn't actually collecting this information in March, but we elected by communicating with the data collection team to retroactively fill in the socio-demographic and economic data of the COVID-19 cases that we had at this point. However, as you can see, also in September, when everything switched over to CCM, there was a spike in missing data as well. So the y-axis here is the count of cases that have missing data with respect to socio-demographics or socioeconomic data, and the month there just on the X. So even though we were mandated and also enabled to collect this data, there were still some hurdles that were involved. At a local level, the data collection team didn't actually know how this information was used in a meaningful manner. So there was a lack of communication going on. So this meant that either sometimes the data wasn't being collected, or additionally, if it was being collected, it was put on a lower priority list, being entered into the either IFIS or CCM at the time of when they were collecting this data. So Sometimes during the collection process, and additionally, it was known through talking with the data collection team that the conversation with the case positive individuals doesn't inherently allow for these sensitive questions to be asked. And also when and how to phrase these questions were also a complication that was noted. So even though, as I mentioned, the questions were asked, sometimes they just weren't entered. So next slide, please. So this leads to missing data. Missing data, I know this is kind of going on to the analysis section of the presentation, but I think inherently these topics are linked together. So when you talk about one, you end up talking about the other as well. This leads to many problems, but however, specifically with sensitive data collection, it is inevitable to have missing data. It reduces statistical power, so you're less able to detect differences in the data. And conversely, it's the total opposite, that if the data is inherently missing bias to one demographic or another, these estimations or measures of effect can be overestimated. Overall, it just leads to decrease in external validity of any analysis that you do. And especially when you have lower case sizes like Peterborough does, it hinders you. You are inherently held hostage to the missingness because you can't do anything about it regardless. So it complicates things. Assumptions, imputations, omissions, conclusions, and knowledge translation all get hindered in this process when you have missing data. So I just have a brief little example here that these two tables, next animation as well, represent the same subset of the population, but with a small data size, the mean age on the left table there is 39 and the mean age on the right is 29. So just having four or five missing numbers, the outcome or the measure that you're looking at is totally different. And it's also biased on the left-hand table to people who identify as male. Next slide, please. So when you are collecting data, knowing the type of missingness that you have can also inform you what the issues are going on. So there's three main types of missing data. You have missing it completely at random, which is the best kind. It means that there's no inherent pattern going on in your missingness. It's not biased to any specific demographic whatsoever. However, the next one, missing at random, or MAR, is missingness that is related to the observed observations, but not the unobserved, which means, for an example, if you use that same tables that I had on the other slide, if you have missing data it happens to be the case that people who identify as female are less likely to answer the questions that you're going for whatever reason whatsoever. And that leads to a bias within your data. So when you go forward with any analysis, this bias ends up getting carried over. However, with small case sizes, you may actually be dealing with missing not at random, which is the worst kind, and you cannot do anything with it, which means that there is a two-level missingness inherently in the data that for some reason, if again, looking back to the previous example of age and gender, so gender identification, that for some reason or another, people who identify as female are less likely to answer the age question. And it could also be the case that people who identify as female and or younger or older for some reason or another are less likely to answer the question as well. So there's two levels of bias that are inherent there. And when you have low case sizes, like Peterborough does, it's hard to differentiate going into the data what that could be, because you just do not have enough signal and enough case size to differentiate where any potential bias will go. So what these two last missingness let you know is that there could be an issue with the way you're collecting the data. Next slide, please. So our solution at a local level, as I mentioned earlier, was communication with the data collectors. With Peterborough, because we have a smaller team, it allowed me to actually go in and talk to the people who are collecting the data and let them know that the usefulness of the data that we are collecting. It also ensures communication of practical outcomes and Additionally, it allows for refinement of case definitions. Now, through these communication processes, we did create our own best practices document, which allowed phrasing of certain questions, case definitions, and who could potentially be involved or exempted within a case definition. So it allows for clear, consistent guidelines for recording the data and reporting the data additionally. And graciously, Public Health Ontario and Toronto Public Health had documents that we're able to utilize as well to help inform our own case definitions and ensure that they are relatable to what it was already released. And additionally, through these communication processes, events, talking to them, it allows us to pinpoint also any bias or limitations in the data. Because without talking to the people who are actually collecting this information, we won't know who's potentially not being included in our case definitions, or who is, or if there's potentially one demographic or another who is less likely to answer these questions as well. As a brief example, household size, as mentioned earlier in the presentation, we had to refine ours to make sure that we are just using household size to represent household-related income, and not the people that are living in the house who potentially could transmit to each other with regards to COVID, but actually more representative of the economic, how liquid these people are with their money to help with how it relates to health-related outcomes. So we're getting that household-related income measure. And that's what I have. Next slide, please. I'd like to thank my manager, Jane Hoffmeyer, on the Foundational Standards team, the manager of the COVID-19 contact management team, Patty Fitzgerald, and all the nursing staff for this process, because without them, we wouldn't be able to refine our case definitions and get this data, and also to the people who agree to answer these questions, because without that, this information, we can't actually help them in a meaningful way. So thank you.
Thank you so much, Dylan. That was really helpful, particularly around your solution, communicating directly with the data collectors in terms of, having an opportunity to share with the usability of the data and the impact that collection has in terms of analysis and use. And also, I'd like to appreciate the fact that you're sharing gratitude for the people who are actually agreeing to fill this data, because sometimes we forget that we see data as numbers and not the people behind those numbers. So that's very important. Just reminding everyone, if you have comments or questions, please feel free to use the chat box, or you can keep them towards the end if you want to share with us verbally your thoughts. So our next presenter is Dr. Fareen Karachiwala, and I'm really looking forward to also sharing her learned lessons or experiences, challenges from York. Welcome, Dr. Fareen.
Thanks so much. And thank you to PHO for organizing this great learning exchange. I think it's a very important topic and nice to hear from everybody. And actually, Dylan, a lot of the similar themes I think have emerged in our health unit too. So it's really nice to know that, well, we're not alone, but also we can kind of muddle through a few of these challenges together. So as Samia mentioned, I'm Fareen. I'm one of the Associate Medical Officers for York Region. And sorry for the long, name, but also title there. It's kind of a double whammy. And just before getting started, I just wanted to give a quick thank you to our planning team and operations team, and also Great Health Equity Collaborative, who really helped inform this presentation and some of the discussion points. I will get into our model of health equity team sort of throughout the discussions. I think it's somewhat unique in Ontario, so we'll talk a little bit about that. I guess we are one of the health units who maybe is sort of midway through this process, so we weren't necessarily a very early adopter. We're waiting for the legislation from the province to start collecting, and we did begin our collection around mid to end of July. And then, of course, where we're located, there have been a surge in cases like many people have experienced in the second wave. And some of that has presented quite a few challenges when it comes to the SES data collection pieces. And so now we're really at a point of trying to put our heads together to figure out what more can be done to improve the completeness and data quality. So next slide, please. So just to give a sense of the numbers, and it was helpful to see some of the provincial averages as well. Our completeness has not been that great, as you can see from the slide. So from collection period onwards, so July 21st till our last pull on the 9th of December, we've had 26% of confirmed cases answer at least one of the questions. I put a few bullet points in there just to really make the point that we used to be better, I guess we could say. So sort of, you know, in the summertime period, we were at 74%, had a big push to collect. And of course, think it's quite important. And this is very valuable data for us. A lot of our social services and other partners have been asking. I'm not going to go into too much of our trends and what we've been seeing, but we have mirrored quite a few of what's been seen provincially, what's been seen in other jurisdictions that have reported more publicly on this in terms of our rates being higher in visible minorities and the Black population, people experiencing low income. So it's something that's not a surprise, but obviously something that we want very rich data on because of the important implications that that holds. So this is just really to make the point that as we went into our second wave with really increased case counts, our capacity to actually do interviews with each of our cases was quite compromised. We are now getting back to that in a more significant way, which is very promising, and the data is getting sort of better as we move through later on in the month, but you can see that there's been a significant decline in terms of the completeness. And then I just wanted to make the point as well that one of the gaps for us, and we've heard from other health units as well, that they're in a similar boat, is when we're dealing with congregate care settings, so even long-term care, retirement homes, often the director of care or somebody is our proxy for an actual resident case. And those questions tend to be missed pretty systematically, which of course results in all sorts of bias, as Dylan had a nice little framework for that, which was really, really helpful. Next slide, please. So just to go into a bit more detail, if somebody did select do not know or prefer not to answer, we did count that as complete because they responded to the question, but just so you have a bit of a breakdown on that. And I think in the first webinar PHU you all held on this, I know this theme came out as well in terms of more people answering prefer not to answer when it comes to household income compared to other one of those questions. And then quite a few on the do not know when it comes to household income. And I believe the languages and household makeup don't contain the do not know question. So yeah, that's all I'll say about that. I know we're sort of short on time. Next slide, please. So in terms of the why behind this all and what's really driving the lack of complete data in York Region and probably other places in the province. So for us, I think the main driver really was those surge in cases. So what ended up happening is we had to move to more of a triage model where we could only do complete case interviews on what we were calling high-risk places, or people who were working in environments that they're more likely to spread in. And so that had a whole degree of bias associated with it as well. And for a large portion of cases, for some time period, that information wasn't being collected. And that was sort of in the peak of it. We've now luckily moved to a new system where we are back to incorporating these questions, because we really wanted to get back to incorporating these questions and doing the analyses on them in a sort of safe and responsible way. So that is getting better, and we've moved to what we've called a sort of outreach plus model, collecting this information. While there, it was quite limited. We played around with different ideas around online tools and things like that, but I will talk about that in our last slide. Some of the things we're hearing from our frontline staff and people asking the questions is sometimes the length of the tool can be limiting. I think what people have really experienced in the second wave is quite a bit of resistance from when we're actually calling people. So not just in the area of these questions, but in general, people are a lot more reluctant, is what I'm hearing, to share information about where they've been, who their contacts are, and a whole bunch of different factors playing a role in that. But it's been challenging, and I think sometimes our frontline investigators too are feeling concerned about the rapport. They're really trying to get at the, where have you been part, what's the acquisition, and get those critical pieces and then sort of quickly sign off, especially with the high case counts and the pressures around that. There definitely is still challenges and comfort issues around asking the question, and I'll talk about how we addressed some of those as well. And then of course we always have sort of turnover, new staff, changing teams. And so trying to keep up with that training and the why of it all can be challenging. I think one of the things which I'll talk about is just, oh, sorry about that. Yeah, so I'll just be quick in the next slide. But yeah, the last point there is just, I know some people get worried about when you're asking about income questions and it gets into the territory of, I might be experiencing financial barriers or support issues around even being able to isolate and things like that, is the so what after that, and what is that level of support that we can provide to people in terms of community resources and being able to navigate that. And we don't always feel comfortable in that domain, and that can lead to sometimes people either not asking the question or not feeling very comfortable in doing so. Next slide, please. That's great. So in terms of some of the enabling factors or things that have helped or gone well in this regard, we do actually have a health equity collaborative. So it's something that I help lead with 2 of our other nurses and a manager, actually 3, and then a manager. And it actually sits right within our Health Emergency Operations Center. The whole idea there is to provide that equity lens to the entire response. And of course, part of this was the training for the data collection, supporting that process through and continuing on with that. So there was quite a comprehensive training that we ran in July, and we're very happy to share some of those materials. One of the very useful products that was developed was this FAQ document that actually provided a very clear script for the investigators to use, because it can be tricky asking these questions, and again, the comfort is not always there. So having a little primer on it, it was sort of a 7-page document. It goes into why exactly are we asking these questions. It goes into some of the more commonly asked questions, either that an investigator might have around why they're asking this, or that a client might have that an investigator is then, having to respond to. So some of those things are addressing, is it racist to collect this information, and how do we actually talk through that? So there's a little blurb on that. Again, really happy to share. It's a very well put together product by our nursing team there. And then a few other questions around, do I have to answer? What's the legal basis for this? And just some of those things that are at the back of people's minds. And I think that was a big enabler. And then, of course, one of the biggest things really was shifting to a model with more ministry supports, more doing the case management. And this way we're collecting that information on all of our cases and not just a high-risk subset, which could lead to all sorts of biases. I will say we haven't fully tackled the problem of how to get around the congregate care settings and the residents in those settings. I think that's going to require a bit more of a hands-on approach, but we are trying to put our heads together and really think through that. Next slide, please. So in terms of a few of the solutions or things that crossed our minds and what we're looking at doing more of, in that height of the surge, we were sort of playing with these ideas of, could we do an electronic survey so that everybody of our cases, even if we're not doing a full phone interview with them, everybody would get a link to complete at least the 5 questions. But then there's all sorts of tricky issues that you run into with that as well, in terms of we know there's growing digital inequities and not everyone's able to access those online platforms. And then toyed with the idea of doing more of a subsample data collection and calling a random population of cases to have that, and using some of our student capacity to be doing that. Luckily, we were able to get to the more fulsome case follow-up more recently, which has been helpful. Another thing we talked about is actually doing more of a communications campaign as to why we're collecting this, so the public knows that when we phone, we do want to really get to these questions, and these are all the very important reasons as to why we want to need to do that. I think in general, with any sort of new thing you're doing, having change management, deliberate change management process is really important. So talking about the idea of having champions, people who really understand it, and doing some of that peer-to-peer with our frontline investigators as well. I think now that we do have some preliminary results, sharing that back with our frontline team is really important, so people can see that there are clear patterns that are emerging, and they're actually quite alarming. And this is really the basis for collecting that information and that data. And then I think just the last piece, as I alluded to before, we are also building in some general universal questions around if people need extra supports, whether it comes to isolating, getting groceries, all those kinds of things. And instead of sort of asking the question of, do you need that support, and waiting for a response, yes, offering it up, those general set of resources and information to everybody that we speak to, because there could be quite a bit of reluctance in actually sharing that you need that support. And there's all sorts of trust issues, since we're a government agency at the end of the day, and people don't tend to like that very much. So having sort of that information and building up some capacity within our teams of how to navigate that. And we do have some social workers, even within public health and across the branch, that we're thinking about the best way to rely on those people or refer for those few cases that might need more intensive navigation support. And we're hoping that will also be an enabler in terms of asking these questions and getting at these 5 questions, but also the piece around what more supports, if any, do you need. I believe that's all I have, so I'll stop there. Thanks.
Thank you so much, Dr. Farine. That was really helpful, especially the idea of having the Health Equity Collaborative as a foundational piece of your response. That is actually a key recommendation in an upcoming environmental scan that our team has done in terms of how health equity has been embedded in the pandemic response. So it's wonderful to see that York is doing that, as well as thank you also for offering to share some of the trainings that you've provided for your team to increase comfort. That is, we're happy to then share it back with the participants of this webinar. And yeah, just also the fact that maybe as a way to improve answers to these questions is offering back all of the things that you've said in terms of services, or like meeting people's needs where they're at, as opposed to just asking them the questions without offering them services. So that's wonderful to see that as well. So our final presenter is Liz Carson from Public Health. Welcome, Liz.
Thanks, Samia. I just want to start off by disclosing that, as many of you know, Toronto started asking socio-demographic questions of COVID clients a little earlier than it was rolled out province-wide. And our race question is a little different than the one that most of you were using, but it does lead to comparable data. I also want to mention that I'm focusing on ethno-racial identity and income data in my section, because that's what we've done the most with in Toronto. And lastly, I want to acknowledge that different jurisdictions obviously have different resources and different amounts of data, as well as different demands from the community for this information. So some of my examples are what you can do with a lot of data and a lot of demands from different stakeholder groups, and also a large EPI and analytics team. So please just keep that in mind. Next slide, please. So the first thing you'll need for your analysis is a benchmark for comparison to figure out what your numbers actually mean. So depending on whether you're looking at rates or proportions, and more on that in just a second, you'll need to identify your denominator data or your comparator data. The census is obviously our gold standard for population demographics, but there are some challenges and limitations with the census, with the most glaring being that most data are from 2016, almost 5 years ago. And there have been population demographic changes since, not to mention that the census might underrepresent certain groups impacted more by COVID-19. We considered a few options to try to model or project some more accurate denominator and comparator data, but we stuck with the census for consistency, simplicity, and transparency. We just list the caveats on our website. You do have to be careful with the nuances in the census data though. For income, in order to match the data you're collecting, you'll need the count of individuals in your jurisdiction by household income bands. Through our community data program, we were able to access the count of individuals by individual income and the count of households by household income. But for the count of individuals by household income, we had to submit a custom request to Stats Canada. I believe PHO is requesting these data, or maybe it's the ministry, is requesting these data for Ontario disaggregated by PHU, and they are planning to share if Stats Canada's okay with that. So for those of you who haven't done this yet, you might get to skip that step. Another analysis step is deciding if you want to create a rough estimate of the number of your cases living below the low income measure. I think we're going to be covering this in the Q&A section, so I'm going to hold off on discussing it for right now. I'll move to another major consideration, especially in these times of intense public scrutiny on epidemiological data, and that's whether you want to use proportions or rates to communicate the data story. We debated quite a lot on what more easily facilitates interpretation, and both internally and externally, many people are firmly in the rates camp, but just as many seem to be firmly in the proportions camp. So we decided to do both. They both have limitations. For proportions, they're great at telling the relative story, but you're missing out on the absolute angle. And for rates, you always need to refer back to the overall rate amongst your clients with valid data for comparison purposes. And that's tricky because unless you have perfect data collection, which based on the last two speakers and our experience seems very unlikely, that rate is probably different than the true rate in your area. So it can just lead to some confusion. This becomes even more complicated when you want to start comparing over time, because you really need both the absolute and the relative measures to tell the story. Once we started trending over time and we look at cases by month at the moment, we realized that we also needed a rate ratio to help tell the story. And this allows for another relative look that doesn't need that second data point of your population comparator like the proportions do. I'm going to show you a few examples of the visualizations that we're using in Toronto on our website, just to see how the data can be shared from our experience and also to help explain some of the stuff I was just talking about. Next slide, please. So this is the way we've decided to show the overall proportions. So you can see that the green bar is the share of each ethno-racial group in the population based on the census, whereas the black bar shows the percent of COVID-19 cases that fit into each ethno-racial group. So where the black bar is taller than the green bar, those groups are overrepresented. We saw this design from somewhere in the UK at first, and it tested better internally than other designs, so we went with it, and we've gotten pretty good feedback on it so far. Next slide, please. This graph pivots a little and presents the data as rates and also brings in the component of time. Our data are presented in Tableau, so there are some filters that the viewer can select. And here I've selected the lowest household income band, one of the middle household income bands, and the highest household income band. An essential component of the absolute story over time is the overall rate, which I just mentioned. This is the gray line. So this is the overall rate among our cases with valid data for this indicator. You can see that it moves around a lot, which complicates the story. So the visualization isn't perfect, but you can see here that there are inequities based on the slope across the three income groups within each month. And you can see the fact that the inequities have persisted over time. And you can also see that the overall case rates have increased across the board over time. Next slide, please. This last graph I'll show you is the rate ratios for the ethno-racial groups by month. And here you can see the filters I was just talking about where you can select individual race groups. This is great for trending the relative story over time, but as I mentioned, it misses the absolute part. Our recent data story in Toronto shows how important both the relative and the absolute measures are. You can see quite a bit of fluctuation in the relative contribution of each of the ethno-racial groups over time. But the absolute rate in all of these groups has increased from September to October and based on preliminary data into November as well. Next slide, please. So I'm going to spend a little less time talking about framing and knowledge translation, but it's actually the most important part. The last thing we want is for these data to be used to direct blame at certain communities, which increases the stigma that lower income and racialized people already face. So you have to contextualize the findings using the social determinants of health and inequity language. You have to emphasize that these inequities are based on pre-existing health, social, and economic disparities, systemic racism and other discrimination, a higher likelihood of being an essential worker or living in housing or using transportation where physical distancing is difficult, and a lack of access to healthcare and social services. That's an essential part of the story, and we hear from our partners that serve and represent racialized and lower income people that it needs to be included when we're communicating the information. Where possible, it would be ideal to complement the quantitative data that you're collecting with qualitative or even anecdotal data as well. Our quantitative data aren't good enough to tell the stories behind the stats, and you need people with lived experience to explain their view to contextualize why the rates are higher in certain communities. We were lucky to be able to do a consultation with agencies in Toronto that's led to some rich qualitative data to help us plan the response to and the recovery from COVID-19. And many of you are possibly doing this at least informally in some of your partnerships as well. This will help ensure that there is narrative justice. And this is a term that's very new to me, but I like it because it implies that communities impacted by the information you're sharing need to participate in the messaging and framing so that it can actually be used to improve their circumstances. Generally, communities who are underserved and under-resourced do have a pretty good idea of what they need, and we need to listen to make our data actionable. Another way to make our data actionable is to actively share it with those who can use it in their advocacy, programming, or planning work. In Toronto, we're lucky in some cases to have mobilized advocates and community leaders who we can connect with when we see relevant trends in the data. And we're trying to leverage and foster relationships with our community partners and also other city divisions. Lastly, it's important to keep reflecting on the limitations in the data that Dylan and Farine covered and being upfront about them in their messaging because they do lead to biases. And it's also important to acknowledge how heavily the trends in these data are due to access to testing. We're only looking at reported COVID-19 cases here, not all of the cases. So if the rate group is lower, it might also be a reflection that they're not getting tested at a high enough rate. Next slide, please. I'll try to go over this very quickly. I know we're short on time. So I'm just going to briefly touch on how these data have been used. So as I mentioned before, we've been able to share our data with city staff and community leaders and advocates who have used it basically to add weight to their existing arguments for better supports for their communities. One of the outcomes of that is the city's equity action plan, which includes 25 actions to reduce inequities, and you can find more about it by clicking on the link in the slide. There's a specific focus on low-income communities as well as Black and Indigenous communities. And our work has also been cited a lot in the media, who are an important partner because they drive a lot of government action, probably a lot more than we'd actually care to think. And I also just want to finish by shamelessly boasting that our race and income dashboard has received almost 2.5 million views since we launched it in July. So people are interested in these data and they are taking them in and hopefully using them to tell stories with an aim of reducing inequities. And that's it for me. Thanks.
Thank you so much, Liz. That was really incredible. And it's wonderful to see the journey of that data from collection to use, as we are not, we should not be collecting for the sake of collection, but for actually changing people's lives and addressing all the inequities that you've always talked about. So in the next few minutes, I'm going to have my colleague Caroline address some of the questions that came in. Thank you so much for all of you who registered and provided us really some incredible questions to pose to our panelists, and then we'll have a chance to hear from you or read some of the comments that are coming at the chat box. Caroline.
Hi, so again, thank you so much for the presenters. And thank you for the attendance, for showing up today, but also we'd asked you if you had any questions you wanted us to start off with and to share, and thank you. We got a lot of submissions, and the interesting part is there were quite a few themes that were common. And so what we've tried to do here is just kind of come up with a common theme or a question within each of the different categories that we've spoken about today. And so your question might not come up, so feel free to share in the chat box in the discussion section coming up. And just to let you know, we did get a few questions that might be out of scope for the presenters and for us, but please do pose them, knowing that we can still kind of put the questions together and go to see if we can get some answers. And so under data collection, I know, Liz, you brought up income, and that came up more than once. So, and we've had a lot of discussions at PHU as well. How can we combine income with household size to really try to understand, Dylan, you called it liquidity. It could be kind of really how much money you have at the end of the month. And so, yeah, go ahead. You can, maybe Liz, you can start since you had it as a bullet point, and we'd love to hear from Dylan and Farine as well.
Sure. So the household income bands in the question we're using were actually delineated specifically so that you can loosely estimate the limb before tax using the household size field as well. We report on both, like the individual bands specifically and the percent living below the limb, but the percent living below the limb is great because it tells the story in just 2 figures. So a lot of people can use that information easily and accessibly. So we have some SPSS syntax that I can share with anybody who's interested. I don't know how many of you use SPSS. We normally use state or assess, but for this, we're using SPSS. But overall, basically, each income band has a corresponding number of people living in the household whereby it's below or above low income. So for that lowest income bracket, 0 to 30,000, everybody's low income regardless of household size. For the 30,000 to 50,000 bracket, it's low income for 2 or more person households. In the 50,000 to 70,000, it's low income for 5 or more person households. And for 70,000 to 100,000, it's low income for households with more than 10 people. And then anything above that is not low income at all. Like I said, I can send that out. I could also just pop it in the chat as well if people just want to take it away now.
Sure. How about, yeah, Dylan?
I was gonna say, yeah, if you could pop that in the chat, that would be great. Because yeah, we're working on that right now. So we actually use R predominantly here at Peterborough Public Health. With regards to how we improve response rates with income. Overall, in general, like we're experiencing right now, we have slightly above, like closer to 30 to 40% missingness with regards to all of our socio-demographic or socioeconomic questions. I believe someone asked, like, what is the cutoff in the chat? I'll just touch on that briefly. When I was speaking with other epidemiologists on our team, if you have 20% of missing data, generally that's kind of a red flag that you should try and look and see what's going on, specifically because when you go to aggregate it more by demographics or socioeconomic status, that missingness can then automatically be overrepresented within specific groups. So anything you try to aim below 20%, I think that's kind of the rule of thumb that we use, but it's different, right? And then if you have a little bit more data, you have a little bit more fluidity with your options with regards to missingness. Now, specifically with regard to response rates, our situation will be a little bit different, even though we are getting a little bit higher case counts here. I think it's because we have less cases, the rapport that our data collectors are able to try and get with the people that do become case positives they can spend a little bit more time with them. Additionally, we just try and make sure that we frame the question and find a timely manner to when to ask it. So we suggested usually around 3 to 5 days after, like during follow-up, to try and start asking the little bit more sensitive questions with relation to socio-demographics or socioeconomics. And that suggestion of providing services and giving suggestions with services up front, I think is great. And I'm going to take that back to our team because it automatically, it sets up this standard that we are here to help you the best way that we can. And that is, I think that's a great suggestion to try and improve response rates just across the board.
Thanks so much. Yeah, I actually jumped the question because I was excited about the income, but if Tarun, you can speak to either and how you've improved rates. Specifically, what about conversations with staff? And also, how have you used the data in calculations?
Great, thank you so much. Yeah, so I probably won't get into the nitty gritty on the cutoffs there, like my epi colleagues, because probably our planning team is better able to speak to that. But in terms of the general strategies to improve response, I mean, I think sort of taking a step back, there's a few reasons why that data is missing. So we saw that there is some proportion of folks that answer prefer not to answer, counting that as sort of missing because obviously we want the actual value. People answering do not know, folks either not asking or participants not wanting to respond to that question or any of the others. So I guess, you know, we've used a range of strategies and are thinking through going forward what more we can do. I do think an important part is the explaining the why or the rationale of it all. And part of that wording is built into our script around that. And like I said, I'm happy to share the exact, you know, word for word, how we kind of wrote that. Both to the individual client, but also to our staff actually asking the questions. That's a neat idea about the, you know, asking it on sort of follow-up calls. I think unfortunately we're in the position where probably it's different staff doing some of the follow-up check-ins compared to the initial investigation. And so we don't always have that continuity or ability to build that rapport. You know, we have toyed with the idea of a more public communications campaign, letting the residents know why these questions are being asked, or asking for people's participation in that, and then also helping with our staff, and then feeding back, like I said, to our staff some of the results that we've seen so far and some of the trends, and kind of reiterating why that's all important. So those are some of the things we've talked about so far here at York.
Okay, Liz, did you have anything else to add for either question before we move on to the third? Okay. So the third one also came up a few times from people in different wordings, and that's some of the discussions that have been going on around once the data is collected, what is the role of impacted communities? How can we guarantee that they have ownership and say in how we use the data and access the data? And so, you know, maybe it does, you know, we know that also the ministry is having some conversations, but we wanted to know if health units have had any of those, and what has, maybe tell us a bit about how you approached it and what the status is now of those conversations.
I can go ahead on this one if it's all right with the others. So we were really worried when we first rolled out our analyses and our findings that we would get sort of a lot of demands to access the data. We didn't actually get that many demands from community agencies or, you know, people who represent racialized and marginalized communities to directly get the data. But we are having conversations with people about ownership and use. And I think one of the ways we're addressing some of those concerns is just by being nimble in our response to data requests. So if we get a data request for a specific type of analysis from, for example, an agency representing the Black community or the South Asian community, we will prioritize that and we will try to fulfill that in order to, you know, to help give them the data to support the work that they're doing. And of course, if there are agencies or I guess academics or anybody really who approach us and say, you know, we would really like to access your data for this specific purpose and we have the skills to do the analysis, then we will send them to our research ethics board and they can apply to get our data directly and do their own analyses. So we're definitely conscious of this. And of course, as I mentioned, like going to a wide variety of stakeholders and making sure that you're incorporating their feedback into the framing as well, I think is an important part of that, because if they don't have concerns about how you're presenting the data, then they might not necessarily want to present them themselves in a different way. So I think that's another strategy.
Okay, so I guess it's two pieces. It's how we share it, and then if you want to write it up, what has been the engagement process around that to make sure that Indigenous or, sorry, that racialized, I know you collect Indigenous data, that those perspectives are being reflected as well. So did Dylan or Farine want to add anything to that?
Sure, I can speak a little bit about the discussions that have happened at York. I think it's a really good and important question, and we've been talking a lot about that. I think with our issues around missing data and quality, it's part of the reason we haven't reported too publicly on this yet. We've been sharing some of our findings with our internal stakeholders, and I'll talk about a table in just a second. And then part of the other reason is because that wholesome engagement hasn't yet taken place, and we're kind of in these initial stages of thinking through how to engage the correct community groups, framing the messaging, framing the recommendations, everything that sort of comes from that. Since COVID started in York Region, there has been what's called a 3C table that's been set up. It's a COVID community coordination initiative. and our health equity collaborative does sit on that group, and it's a group of individuals that are sort of service providers, United Way, faith-based organizations, and the rest that all kind of are have sort of subgroups as well. But I think that's going to be a good starting point. And we've gotten, just to complement some of these quantitative data pieces, we have gotten a lot of really rich qualitative information from that group. So sort of doing focus groups around what they're seeing with vulnerable populations, and we're kind of happy to share some of those findings. So that's an existing place that we can go to and plan to, but that's part of the reason we haven't reported too publicly on this. And I think talking through those principles of all of the OCAP and other principles is really important. That's sort of where we're at. It's like emerging, I guess you could say.
Okay, and I'm mindful of the time, but there was also another question. It came up in the chat box and a few times in the submissions around Indigenous data. I know, Toronto, you collect a separate question, but I'm wondering about the others. How have you entered that? How have you approached that? And so what do you have experience with looking or capturing Indigenous data?
I can say for Peterborough Public Health, what we ended up doing is setting up a separate script with the known local Indigenous populations or peoples that are here in the Peterborough County Health Unit area. And then we use in CCM, if it happens to not be in the data entry drop-down list, we put other, and we make sure that the people that are collecting the data just specifically put that in the other and make sure we type in the specific demographic there. That's kind of how we go forward, and that's how we have done it. I think that's the, if I'm answering that question correctly, I may have misunderstood.
Okay, so you have a separate question, but when it's entered, it goes under other, and you clarify what that response is.
Yes, that's how we do it. We have set a framework. So like other people have mentioned, we set up our own framework and have an own process document for framing these socio-demographic questions that help then that are used. And we just actually set this up and sent it out recently to our data collectors. So they have clear case definitions, and then to also that would, I think, also help improve our response rate as well. So
thank you. Yeah. Liz or Farine, do you want to go ahead?
Sure. So we haven't transitioned to CCM yet. Full disclosure, PHO probably knows that. Other health units might not, or they might, I don't know. But once we stop using our City of Toronto in-house information system, we are actually not going to be entering Indigenous status into CCM. Our urban Indigenous partners in Toronto, they don't, seeing as there's no regulatory authority for the data to be collected at a provincial level, they don't feel comfortable with us collecting the data and then sending it to the province. So we are going to develop a separate check market survey. Check market similar like SurveyMonkey or something like that. And we're going to ask all of our clients if they identify as Indigenous. And for those who do identify as Indigenous, we're going to collect the information in this check market survey. And then we're going to link the check market survey back to the data in CCM using Case ID. So that's another potential, but more cumbersome solution.
Caroline, you're mute.
Yeah, I recognize we're actually over time. So did you have anything else to add, Farine, before we wrap it up?
No, not too much more. I think, I mean, it's a good question. We're following the provincial questions for now. So we aren't at the stage of collecting Indigenous status and would be engaging before doing any of that.
Okay, thank you. So Pam, do you want to wrap up, or Samia?
Yeah, I can. I think we've addressed most of the questions that came in the chat box as we were going through the preset questions. The only thing that I wanted to just mention is, well, first of all, to thank everybody who have, stayed with us even beyond the time. It's often difficult to estimate how long these things take, but it's a testament of how wonderful the conversation has been. We're gonna launch the poll for the last question, so just we understand perhaps what's the next area of interest that folks might have. Perfect. As we might organize another one of these learning exchanges, we are also going to be sharing an evaluation link with everyone. And as mentioned at the beginning of the session, that this session is recorded and will be shared with the participants once it's online at the PHU website. I think I can. Perfect. So we have like 30 seconds of the poll. Awesome. Looks like a majority of the folks are interested in learning more about applying an equity principle on data sharing, analysis, and interpretation. So a lot of what you've talked about, Dylan, Farine, and Liz today. And community engagement, and not only community engagement, but there was an excellent question around how do we seek community feedback. There was a question also that came from, not a question, a comment that came from Montreal, folks in Montreal beginning to implement socio-demographic data and wanting to connect with the speakers. So our last slide has our speakers' contact information. And if you're all okay with us sharing that as well for others that might have questions or might be going through the process, especially our colleagues in Montreal or other provinces. Perfect. And is there any last words that Dylan, Pam, Liz, Farine, or Carleen have before we wrap it up? Okay, it's a wrap. Thank you so much all for staying and listening and sharing, and also bringing all your positive energy to sharing all the wonderful challenges as well as the potential solutions that we all have as we kind of muddle through this process of learning together. Thank you so much. Have a wonderful rest of the day. Take care.